So I'm going to start, present this case, and I hope it, elicits a good discussion. So this is a case we saw about a year ago. Our PERT team was started in 2014. We had a number of cases since then, and this is from last year. So it was an 80-year-old woman, history of hypertension, had a DVT in the past, who came into the emergency department with 3 weeks of weakness. This DVT she had was provoked in the setting of knee surgery, and she had completed 3 months of anticoagulation. At this point was off anticoagulation. When she came into the emergency department, she was initially afebrile. Her heart rate was 63, normotensive, but she was notably hypoxemic. Saturation was 81% on room air. On nasal cannula, it was 92%. Otherwise was well appearing. She did have elevated JVP. Her heart rate was, her heart exam was normal, lungs were clear. She did have cool extremities, and neurologically she was intact. Her initial labs are notable for an elevated white count. An AKI, her creatinine was 3.1, her baseline a few months ago, prior to that was 0.8. She had elevated transaminases, an elevated lactate, her troponin was mildly elevated, and her BNP was pending. This was her X-ray. Not the best film, but the lung parenchyma looked relatively okay. EKG, pretty nonspecific, maybe some T-wave inversions, a hint of an S1T3, a Q3T3. So while she's there, she becomes hypotensive. Her blood pressure is 86/53 with worsening hypoxemia. At this point, she's placed on high-flow nasal cannula. Her extremities are now very cold. Echocardiogram at the time shows a normal EF, but severe RV dysfunction, moderate TR, RVSP of 53, and McConnell's sign. Heparin drip was initiated because of this concern for PE. A CT scan was done. You can see a big clot in the left pulmonary artery here, and then this is on the right. And then down to the heart, you can see significant RV dilation. So I guess the question is now, what do you do? So our PERT was activated. We had this same discussion as to what to do, and ultimately, the patient was started on pressors and inotropes, and we did decide to give her systemic thrombolysis. We gave her the half dose over 2 hours. She was weaned off vasopressors by the next morning, and we were happy, except she was hypotensive again. Vasopressors were reinitiated. I won't have you go through this again, but again, the same type of discussion happened again. But in the light of day, she ultimately did go through for a catheter-based intervention. This is her angiogram at the time, underwent thromboaspiration, and this was the result afterwards. She also, at the same time, got a small dose of catheter-directed lytics, 0.5 milligrams per hour in each artery for 6 hours, so a total dose of 6 milligrams, weaned off vasopressors and off high-flow nasal cannula, ultimately transitioned to rivaroxaban and discharged home.